Hi, this is Keith. This presentation goes along with Chapter 16, so if you haven't read it yet, then it's a good idea to do that first and then watch this presentation. One quick note. There are a few concepts in the book chapter that are a bit outdated, so I'll point those out and present some new information.
So in this presentation, we'll define HIV and AIDS, discuss how it occurs biologically, and end in talking about the epidemiology and transmission of HIV, AIDS demographics, prevention and treatment strategies, and some issues around living with HIV. The obvious place to start is to define HIV and AIDS. HIV, or the human immunodeficiency virus, is a virus, and this virus is responsible for a breakdown of the immune system through a very specific biological mechanism that we'll discuss later. So then what is AIDS, or acquired immunodeficiency syndrome? Once HIV is acquired, it affects the body's immune system to the point that it cannot combat disease-causing organisms, resulting in a group of symptoms that collectively indicate a disease or syndrome. Now, to receive an AIDS diagnosis, someone must have first a positive blood test indicating the presence of HIV antibodies or HIV virus. And second, they must have a CD4 count below 200 or one or more of the diseases or conditions associated with AIDS. And again, we'll talk a little bit more about what those are. So AIDS is the final stage of HIV infection. HIV emerged in the early 1980s in the form of repeated occurrences of formerly rare diseases among a relatively young and healthy group of men. In other words, what should be relatively young, healthy men, they were showing up and they had AIDS. Now, there's been a tremendous amount of research done since it emerged, and what we know about HIV is constantly being updated, as I mentioned before. So again, just be aware that some of the statistics that you see in this presentation may not be the most up-to-date ones that we have, but honestly, in terms of the statistics and the demography of HIV, there haven't been huge changes in recent years. Okay, so the CDC lists over 20 clinical conditions to be used along with an HIV positive status to diagnose AIDS. These infections are collectively called opportunistic infections, and these are diseases that take advantage of a weakened immune system. For example, pneumocystis carinii pneumonia is a type of opportunistic infection, and that, of course, is a type of pneumonia. Certain types of cancers are commonly associated with AIDS, such as cancers of the lymphatic system, invasive cervical cancer, and a cancer of the blood cells called Kaposi sarcoma. Clinical conditions specifically linked to AIDS include wasting syndrome, where somebody loses an extraordinary amount of weight, and AIDS-related dementia. In other words, basically, the AIDS can affect the brain, which then can lead to dementia. Other infections that may lead to an AIDS diagnosis under certain conditions include candidiasis, genital herpes, and cytomegalovirus. Now, before we get into how HIV compromises the immune system, it's important to define some parts of the immune system. At the most basic level, HIV invades and eventually kills some kinds of leukocytes, or white blood cells, which play major roles in defending the body against invading organisms. Other important parts of the immune system that you might have heard of include macrophages, which are white blood cells that engulf foreign particles and display the invader's antigen. And antigens are large molecules capable of stimulating the immune system and then reacting with the antibodies that are released to fight them. And then there's antibodies. Antibodies bind to antigens, inactivate them, and mark them for destruction by killer cells. So there's a lot of sort of definitions here, but just know that these are some of the important sort of immune system definitions to kind of keep in mind as we talk about how HIV impacts the immune system. But there are certain parts of the immune system that are involved specifically with HIV. So let's take some look at those parts. First, lymphocytes, which is a type of leukocyte, are crucial to the immune system's functioning and include both B cells and certain types of what we call T cells. Another important part of the immune system are helper T cells, um, which are also called CD4 T or more plainly CD4 cells. So these cells are programmed to read, quote unquote, the antigens and then begin directing the immune system's response. So the CD4 cells sort of act like a conductor of an orchestra. Helper T cells display CD4, a type of protein receptor on the outside of the helper T cell. Finally, there are killer T cells, which are activated by helper T cells, which transforms the killer T cells into agents of destruction on pathogens that enter your body. Okay, so now that you have some of the definitions and a bit of an understanding of the few relevant parts of the immune system, let's talk about what HIV is and how it impacts the immune system. So again, as I mentioned before, HIV is a virus. That is, it is a protein-coded package of genes that invades a cell and then alters the way in which the cell reproduces itself. So the protein core of HIV contains RNA or reverse transcriptase. Now, reverse transcriptase is an enzyme that enables a virus to write its RNA into a cell's DNA. So because of this, HIV is a type of retrovirus, which are a group of viruses with the ability to reverse the normal genetic writing process. So why is HIV so destructive to the immune system? Well, where normally helper T cells rush to invading pathogens and stimulate antibody production, HIV injects its contents into the helper T cells and then hijacks this machinery, and then the T cell begins producing HIV instead of replicating itself into more T cells. And then in that process, the T cell is killed. So when the T cell is killed, a huge amount of HIV is then essentially dumped into the body to further infect more T cells. So again, over time, these T cells end up depleting themselves because they're not replicating themselves; they're just replicating more HIV virus, which then is dumped out into the system to infect other T cells. HIV also targets other types of cells, including macrophages, dendritic cells, and brain cells, but it's really the destruction of T cells that is the most damaging. So, just on a quick aside, there are different forms of HIV. Almost all HIV cases in the US involve HIV-1. There's another form of HIV called HIV-2, and that mainly exists in West Africa, and it's less infectious. Under strong magnification, HIV resembles a spherical pincushion bristling with tiny pinhead-like knobs. Now, these knobs are the antigens, which contain a protein called GP120, and the CD4 receptors on a helper T cell are attracted to GP120, which of course is fatal to the helper T cell. So let's review the life cycle of HIV. These different stages are important to understand since HIV treatments disrupt one or more of these different processes. So the first stage is binding and fusion. Virus binds to a CD4 receptor, then the virus fuses with the cell. Then there's the infection phase. So the virus penetrates the cell, and then its contents are emptied into the cell. The third part is called reverse transcription. Single strands of viral RNA are converted into double-stranded RNA by the reverse transcriptase enzyme. The first stage is integration. Viral DNA is combined with the cell's own DNA by the integrase enzyme. The fifth stage is transcription. So when the infected cell divides, the viral DNA is sort of read and long chains of proteins are made. And then finally, the sixth stage is budding. So new copies of the virus are assembled, they bud or sort of spill out of the cell, and then can go on to infect other cells. And as I mentioned before, in that process, the T helper cell is killed in the process. So once budding occurs, that T helper cell is dead, and then the new HIV virus goes out to infect other T cells. So most people develop detectable antibodies to HIV within 3 to 8 weeks after exposure. So by exposure, we mean infection with HIV if antibodies are being produced. So if somebody is exposed and then HIV is sort of established within their system, that is what we call seroconversion. So again, seroconversion is this process where HIV is established in a system. Then somebody might go from being somebody who is HIV negative to somebody who is HIV positive or living with HIV. And so you'll see sometimes in the literature or in when people talk about it that when somebody has seroconverted, it simply means that HIV has been established in their system and they've developed antibodies to it. Now, serostatus is whether someone is HIV negative or HIV positive. So someone who is considered HIV negative is someone whose antibodies to HIV are not detected, whereas if somebody is HIV positive, then they have antibodies in their system that are detected. Now, importantly, T cell count or CD4 count, so that's sort of same way of saying the same thing, is a number of helper T cells present in a cubic millimeter of blood. So in a person not infected with HIV, so this is an HIV negative person, the CD4 count is usually around 1,000, but there is a rather large range depending on the general health of a person and whether the person is fighting off an illness. So that range can be anywhere from 500 CD4 or T helper cells per cubic millimeter to 1,500, but the average is around 1,000. HIV disease usually progresses in roughly 3 stages if a person is not treated with medication or what we more formally call antiretroviral therapy. So, again, these are the stages if somebody is not treated. Stage one is the acute infection stage. So, within 2 to 4 weeks after the exposure, some people develop flu like symptoms, but importantly, other people show few or no symptoms. Now, HIV can be transmitted before it shows up on an antigen-based HIV test. So if someone is having a large number of sexual partners in a short period of time after exposure, they may unknowingly transmit HIV to those partners before a standard antigen-based HIV test will register that they have HIV. But also keep in mind that there are other types of tests, like viral load tests, that can detect HIV much earlier. The second stage is a chronic phase. In this phase, a person with HIV may appear and feel healthy for 10 years or more after becoming infected. So during this time, they may not know that they're infected at all, and it can last a very long time because they may feel fine or look fine. And then finally, stage three is AIDS. In this stage, a person is susceptible to opportunistic infections and is at high risk for dying from those infections if they aren't treated. Now, with proper HIV treatments, someone infected with HIV today can lead a relatively healthy life and achieve an average lifespan if they are taking antiretroviral therapy or medication to treat HIV. And it's standard practice for someone diagnosed with HIV to start treatment immediately to avoid progressing to AIDS. So we call this uh, test and treat. So in other words, test for them. If the test shows that they're living with HIV, then start treatment right away. So here you see a graph of HIV disease progression if it is untreated. So keep in mind, if someone is on HIV medications, their progression will not look like this at all. During the initial acute illness phase, CD4 levels, shown in the dark green line here, fall sharply, and HIV RNA levels, the red line here, increases. So many infected people experience a flu-like symptom during this period, but again, some people just simply do not. Antibodies to HIV usually appear 3 to 8 weeks after the initial infection. Now, during the asymptomatic chronic phase that follows, CD4 levels gradually decline and HIV RNA levels again start to increase, right? So, but the decline of CD4 levels is slow, and the increase in HIV RNA levels is also slow. And so This is a stage where somebody can be living with HIV for quite a long time, up to like 10 years, and not know it because it really isn't sort of impacting necessarily how they feel right away. So they might have some symptoms, but not that many. So after many years, when CD4 levels drop very low, people then become vulnerable to serious opportunistic infections that are characteristic of AIDS. So again, this is the stage three that we learned about. Chronic or recurrent illness continue until the immune system can fail. And again, if somebody's untreated, this could really result in death. Okay, so now that we know some of the biological foundations of HIV, let's turn to the epidemiology of it. So, epidemiology is a study of the incidence, process, distribution, and control of diseases. So, when we talk about epidemiology, the epidemiology of HIV, we're talking about its incidence and prevalence, which we talked about in a previous chapter, and how it's distributed across different groups of people. As you see, HIV is not evenly distributed across the US population. So, we'll talk about this in great detail in just a bit. So, as you no doubt already know, an epidemic is the wide and rapid spread of a contagious disease. We'll talk about HIV here, but also think about, for example, the COVID-19 epidemic. What was the what was the wide and rapid spread of a contagious disease, um, which was COVID? Now, worldwide, the World Health Organization, or WHO, and the Joint United Nations Program on HIV/AIDS, or UNAIDS, have found the HIV epidemic to be one of the most destructive in human history. So let's put a few numbers to it. Nearly 40 million people living, there were nearly 40 million people living with HIV at the end of 2023, and more than 40 million have died because of AIDS. Currently, at least as of 2022, 1.3 million people were infected with HIV. So again, this is something that has been going for almost 50 years, and it's something that we're sort of actively trying to reduce, but it still continues to be a major epidemic around the world. Now, the rate of new HIV infections are declining overall in the world, which is good news. However, the prevalence of infection is by far the greatest in Africa, which accounts for nearly two-thirds of global new HIV infections. Here you see how HIV is distributed across different populations and by gender globally in 2019. Although not much has changed since then. So even in 2025, these trends sort of persist. So you see groups at highest risk are sex workers and their clients, people who inject drugs, men who have sex with men, transgender persons, and sex partners of different at-risk groups. So again, these are the people who are, or the communities that are at highest risk. You'll notice that 38% of the population is sort of other people who are at risk, but don't sort of fall into one of these other groups. Now, cisgender women make up a little over 50% of all cases globally, and many of them are adolescent and young adult females between the ages of 15 and 24. But the epidemiology of HIV in the US can look quite different than it does globally. So in the US, 1.2 million people are estimated to be living with HIV in the US at the end of 2022. Again, not much has changed since then. It's about pretty stable. The acquisition of HIV is showing encouraging declines in the US, resulting in an overall lifetime risk of an HIV diagnosis in the US of 1 in 120. But just saying that the risk is 1 in 120 across the entire population masks large disparities among groups in the US. So we'll explore which groups are at highest risk. This slide presents the number of HIV diagnoses among persons in the US from 2017 through 2021. The line begins at 2017 with 39,000 diagnoses, then drops to 29,000 in 2020. The large decline is likely due to disruptions in clinical care services, patient hesitancy in accessing clinical services, and shortages in HIV testing reagents, and materials during the COVID-19 pandemic. Then the number of diagnoses jumps to 35,000 in 2021, which seems like a wild swing. But the partial rebound in the number of HIV diagnoses may be due to the identification and reporting of HIV diagnoses that were actually missed in 2020. In any case, you can see that the number of HIV diagnoses in the US is around the low to mid 30,000 range. This slide presents the estimated HIV incidence among persons aged 13 years or older from 2017 through 2021 by the transmission category. So the annual number of HIV infections in 2021 compared to 2017 decreased among persons with infection attributed to male-to-male contact, as shown on the left side of the figure, but it remained relatively stable for injection drug use, males with infection attributed to male-to-male sexual contact and injection drug use, and persons infected through heterosexual contact. In 2021, the largest percentage of HIV infections were attributed to male-to-male sexual contact, followed by heterosexual contact, and that has remained the same since then. So here's a bit of a different view of how HIV is distributed by gender in the US. Remember that globally, females made up a little over half of all HIV cases. But as you see here, in the US, males made up 80% of HIV diagnoses in 2020. This was followed by females, and then a much lower percentage of new HIV diagnoses were among transgender women and men and other genders. In this figure, we even get a little bit more fine-grained. This shows the number of new HIV diagnoses in the US by race, ethnicity, and gender. In 2021, Black men who had sex with men represented the highest number of new cases, followed by Hispanic men who had sex with men, white men who had sex with men, and then finally Black heterosexual women. Now, Black heterosexual men, Hispanic heterosexual women, and white heterosexual women were far fewer in terms of cases in 2021. So you can kind of get a sense for who is really at highest risk for HIV in the US. Okay, so we took a look at some sort of broad general trends of HIV in the US. We're going to dig into specific communities here in just a bit, but let's talk a little bit about some of the modes and myths of transmission. So HIV transmission modes have been clearly identified, but false information persists. So let's kind of take a look at some of these. Most commonly, people get or transmit HIV through sexual behaviors and or needle or syringe use. So again, that's sharing needles or syringes during injection drug use. Now, only certain types of body fluids can transmit HIV. Those include blood, semen, preseminal fluid, rectal fluids, vaginal fluids, and breast milk. These must come into contact with the mucous membrane or damaged tissue in order for HIV to be transmitted. So, less common ways that HIV is spread is from mother to mother or mother to child during pregnancy, or also breastfeeding. So breastfeeding can also transmit HIV. You can also get HIV from being stuck with an HIV contaminated needle. And then there are a number of ways that HIV sort of um, can, or in theory, can be spread. But I think we have to look at some of these with some real skepticism. So HIV can be spread through oral sex. Again, that is not common. It's certainly much less common than anal or vaginal sex. But again, this might be a case where somebody is not treated with medication, has a very high viral load, and then somebody on the receiving end might have sort of bad gums or some cuts in their mouth, and that way it can be transmitted. But again, it is much less common than anal or vaginal sex. Um, People can also be infected through receiving contaminated blood or organ tissue transplants. Again, back in the 80s, where we didn't have good tests for HIV in the blood bank system, this was much more common, where blood sort of recipients in terms of hemophiliacs and other people receiving blood from donations who might be infected with HIV. That was much more common. That's not the case now since we have good screening protocols. Here, I think below this, there becomes sort of a lot less certainty, and certainly these are things that I would not necessarily focus on if I were doing prevention work with somebody. So one might be eating food pre-chewed by an infected person. I know of no cases of that ever happening. I don't know why people would want to do that, but I guess in theory that could happen. Being bitten by a person with HIV, again, the likelihood that HIV transmitted in this way is extremely low. It'd have to be quite a bite, and there'd have to be a lot of fluid exchange. Contact between broken skin, wounds, or mucous membranes, sure. Again, it would take an extraordinary circumstance for that to happen. Your book also mentions deep open mouth kissing with sores or bleeding gums. Um, I have to caution around this. So there are a number of places in the book where the book sort of says that people living with HIV should not engage in open mouth kissing. I don't agree with that. I think that it's both stigmatizing and the likelihood of somehow HIV transmitted through open mouth kissing is extraordinarily low to non-existent. And so I think, again, maybe there was one case back in the 80s where somebody with very cracked lips and open sores in their mouth were kissing each other. But I don't think this is a type of transmission that any modern day preventionist would be worried about. But I guess in theory it could occur. It's just something that I think creates more stigma rather than it being helpful. So just notice that there is really no chance for HIV to be transmitted through toilet seats or just regular contact. And certainly there's no fear of transmission through mosquitoes or other blood-sucking insects. Okay, so what is the probability of getting HIV from specific behaviors? So again, um, the behavior that is most likely to transmit HIV is receiving a blood infusion where the donor had blood. This was a big problem back in the 80s when the blood banks didn't have good screening protocols to screen blood for HIV, but they do now, and it really is not an issue now. But certainly, if you're getting blood directly from somebody who has HIV, the likelihood of you getting it is extraordinarily high. So what we tend to focus on more are the things that follow, which the next most high likelihood behavior of getting HIV is through receptive anal intercourse, which means the person who is the receptive partner, or more commonly known as the bottom. Next is sharing injection drug use equipment, followed by a needle stick, for example, in a medical setting, and then insertive anal intercourse, meaning the person who is the top. And then, as you can see, the risk of getting HIV on these other types of behaviors is either low or negligible, meaning that the likelihood is so extraordinarily low that it's something I'm not even sure we should even be focusing on. Um, but importantly, biomedical options like pre-exposure prophylaxis, latex barriers, condoms, dental dams, and surgical gloves, when used properly, can provide good protection and excellent protection against transmission of HIV. So we'll talk about some of those methods later. In the next few slides, we'll talk about different ways that HIV can be transmitted. The most common way is through sexual contact, and the type of sex that is most likely to transmit HIV is condomless anal intercourse. Now, the term unprotected anal sex is used in the textbook, but it's a bit of an outdated term since we now have medications like pre-exposure prophylaxis that can stop the transmission of HIV during sex where a condom is not used. So the preferred term now is condomless anal sex or condomless vaginal sex. Now, as with anal sex, HIV can be transmitted during vaginal sex, and the receptive partner is at highest risk, but HIV can be transmitted to the insertive partner as well. There is evidence that having a circumcised penis reduces the risk for HIV, and so there was a push a decade or more ago to get men circumcised to prevent HIV, and that was particularly done in high epidemic areas like certain parts of Africa. Now, the book mentions some other activities like oral sex, kissing, and using sex toys that have a small risk for transmitting HIV. Of those, oral sex probably has the largest risk for transmitting HIV, although it's still extremely low. I don't think any prevention specialist would focus on the risk conferred by open mouth kissing or through the use of sex toys. One thing that's really important to know is that people with HIV who are taking their HIV medications as prescribed and are undetectable cannot transmit HIV during sex. So we'll talk later about what undetectable means, but this approach is sometimes called undetectable equals untransmittable or U equals U, and it is supported by the CDC. So I'm not sure why the book doesn't cover this in the chapter, but it's important to know that people who are living with HIV and are successfully on treatment, this is a way to prevent transmitting HIV to their sexual partners. Okay, so the next way that HIV can be transmitted is through substance use and injection drug use. So substance use disorders, which are problematic patterns of using alcohol or other substances, are really closely associated with higher risk for HIV transmission. Substances that alter judgment can lead to risky sexual behaviors. For example, alcohol can loosen inhibitions and make enacting prevention strategies like condom use more difficult. Injection drug use, or IDU, can be a direct route of HIV transmission when equipment is shared, because the shared equipment may have blood with HIV in it that is then injected into another person. And substance use among people living with HIV can hasten disease progression and worsen overall consequences of having HIV. So, substance use services for people with HIV can be really important as a part of their overall health care. HIV can also be transmitted from mother to child, although this is much more common in areas of the world with poor healthcare infrastructure and low income areas. Perinatal HIV transmission, in other words, mother to child, can happen at any time during pregnancy, labor, delivery, and breastfeeding. So, women living with HIV can give birth without transmitting the virus, but this requires that the mother know that they have HIV and then are prescribed the right kind of HIV medication that will help stop transmission of HIV to the baby. Now, for babies with HIV, the disease can progress rapidly, so starting treatment early is especially important. All right, now let's turn to some demographics of HIV in the US. So, when we say demographics, we mean the statistical characteristics of populations. In this case, we mean the statistical characteristics of persons who are at most risk for HIV in the United States. It should be said that no one is exempt from HIV exposure, but certain groups as a whole appear to be at greater risk. And importantly, this means that individuals within these groups may not, in fact, be at risk at all because they don't engage in risky behaviors. So we can say that certain groups are at higher risk than other groups, but we really can't say if a particular individual is at risk for HIV within a particular risk group, because that will depend on a lot of factors. So please keep this in mind as we look at different demographics. We're talking about group demographics, not predicting somebody, any one individual will be at higher or lower risk for HIV. So in the 1980s, HIV and AIDS was primarily considered a gay white disease, but today the epidemic has changed across the decades. So Black and Hispanic persons are disproportionately affected, meaning that the majority of new HIV infections are among these two groups. But how should we interpret this? So again, keep in mind that race and ethnicity in the US are really markers that correlate with other more fundamental determinants of health status, such as poverty, houselessness, and lack of access to quality health care. So these other markers may be the real drivers of increased risk for HIV in Black and Hispanic communities. And certainly there are studies that show a direct relationship between higher HIV incidence and lower income. Shown here is a lifetime risk for receiving an HIV diagnosis in the US from 2017 to 2019. So as you see, both Black males and females are at high risk for HIV, followed by Hispanic and Latino males and females, But then you see that males in other race categories are at much higher risk than females pretty consistently. Now, in the US, the most disproportionate impact of HIV has been on men who had sex with men, or MSM. This was true since the beginning of the epidemic in the US, which is a little bit different than it was in other parts of the world, like Africa, where it was and continues to impact heterosexual persons, especially adolescent and young women. Now, why might HIV have spread so fast among MSM? One reason is that anal sex is a very efficient mode of transmission. Another reason is that infections between people travel much more quickly in smaller sexual pools, like gay men. Finally, prevention efforts were slow to take off in the MSM community because it was perceived as a gay disease in the 1980s and was highly stigmatized. Now, in 2022, gay, bisexual, and other men who had sex with men who reported male to male sexual contact accounted for 67% of the 31,800 estimated new infections, and they also accounted for 83% of the estimated infections among all men. The book mentions the idea of serosorting as a potential prevention strategy that some people may use. Serosorting is having sex with a partner whose HIV serostatus is believed to be the same as one's own. So, this is the idea that people who are HIV negative will ask their partners if they are also HIV negative, and then, if so, have sex with them. And people who are HIV positive will ask their sexual partners if they're positive and also only have sex with them. The book mentions this, but I just want to point out that this is a terrible strategy. The reality is that HIVs usually pass between people who don't actually know their HIV status. So somebody who might think that their partner is HIV negative may unfortunately not really understand that their partner may in fact have HIV because their partner hasn't been tested in quite a while. So again, serosorting is not a good strategy. So what are some actual effective strategies to prevent HIV between men who have sex with men and honestly anyone who is interested in reducing their risk for HIV? So one that we'll talk about in more detail later is pre-exposure prophylaxis or PrEP, which is medication people can take to prevent HIV. It is highly effective when taken as prescribed, and again, we'll talk more about that later. The other one I mentioned earlier in this lecture is what's called U equals U, or undetectable equals untransmittable, which is when a person living with HIV takes their medication as prescribed and their HIV levels become undetectable in their body. So this means that there is so little HIV circulating in their bodies that they cannot pass HIV to their sexual partners. Another name for this that you might hear is treatment as prevention. So if somebody is undetectable, they cannot pass HIV during sex, even if that does not involve a condom. A third prevention strategy, of course, is condom use. So condom use has been something that we've been promoting for a long time, and it certainly still is an important part of the prevention toolbox. It's especially important since it can prevent the transmissions of other STIs. Now, early in the epidemic in the US, many women were infected through injection drug use because they were not diagnosed because HIV was seen as a gay disease. Fortunately, that has changed. Although HIV diagnoses among women still have seen a sharp decline, thousands are still diagnosed each year, which we'll see on the next slide. One of the reasons that some women are at risk for HIV is that they may not be aware of their male partner's risk, such as having other sex partners, having sex with men, and using substances. Here you see the frequency of HIV transmission categories among women by race and ethnicity. All women are at highest risk from heterosexual contact. However, white women in the US are also at substantial risk from injection drug use. By the numbers, Black women account for over half of HIV cases in the US among women. Transgender communities in the US are among the groups at highest risk for HIV infection. In 2022, transgender persons accounted for 2% of new HIV cases in the US, but they represent less than 1% of the US population. Now, there are a number of factors that make prevention in this group challenging. First, transgender persons have higher individual risk factors, such as engaging in condomless sex. That can be due to a variety of reasons, which gets to our second point. So, stigma, discrimination, social rejection, and exclusion of transgender people is very prevalent, and this has important implications. For example, because transgender persons may have difficulty finding employment or housing, some of them may turn to survival sex to meet their basic needs, which of course will be higher risk. Another issue is that transgender people may not receive appropriate and competent health care, which could be a barrier to prevention tools like PrEP. Now, perinatal transmission is the most common route of HIV infection in children. By perinatal, we mean HIV that is transmitted from mother to child. The incidence of HIV among children has been dramatically reduced by the CDC recommendations that women first receive routine counseling and voluntary perinatal HIV testing. So rather than only counseling and testing women who providers might think are at risk, we just test and provide counseling routinely to everyone. The second is the use of medical treatments, specifically antiretroviral therapies, to prevent perinatal transmission. In 2020, youth ages 13 to 24 accounted for 20% of all new HIV diagnoses in the US. Importantly, young Black and Hispanic youth had the highest incidence of new HIV diagnoses. So many of the prevention programs for youth focus on Black and Latino communities. Factors associated with risk for HIV infection include low rates of HIV testing, high levels of substance use, low rates of condom use, and higher number of partners than other age groups. This slide presents the percentages of diagnoses of HIV infection by age group for 2020 in the US. So, of the 30,635 diagnoses of HIV infection among persons 13 years or older, 37% of those were among people aged 25 to 34 years. However, 20% were among persons aged 12 to 24 years of age. So the youngest group, the 12 to 24 years of age, are not the highest risk group, but it's still at substantial risk. And if you can give young people the tools and resources to prevent HIV when they're young, then this should have continuing benefits as they age. Now, this slide presents a distribution of adolescents and young adults aged 13 to 24 years living with HIV at the end of 2018 by sex and transmission categories in the US. So among male adolescents and young adults living with HIV, 92% of them were attributed to male sexual contact. Now, among female adolescents and young adults living with HIV at the end of 2017, 85% of their infections were attributed to heterosexual contact, but also 12% to injection drug use. Older adults aged 55 years or older account for about 10% of new HIV cases in the US. Adults aged 50 and older have similar risk factors as younger people, but in fact, they may be less aware of these risks. Because there is the perception that older people aren't or shouldn't be sexually active and should be at low risk for HIV, they are also more likely to have late stage infection at the time of diagnoses. And stigma is a special concern among older people because they already face isolation due to illness or loss of family and friends, and the stigma may prevent them from seeking HIV care and disclosing their HIV status. Also, HIV can be particularly problematic for older people since both age and HIV infection increase the risk for things like cardiovascular disease, bone loss, and certain cancers. Okay, so HIV is also geographically not dispersed evenly. In other words, it varies by the geographic region you look at. So in the US, southern states account for nearly half of new HIV diagnoses. In all regions, the majority of diagnoses are in urban areas, although a significant proportion still occur in suburban and rural areas. It's also interesting how HIV sort of intersects with other epidemics like the opioid crisis. And that crisis, together with HIV, has increased risk for HIV and hepatitis C, and that often occurs in non-urban areas. Here you see the large differences in the percentage and number of new HIV infections in the US by region. Notice that over half of new infections in 2021 were in the southern region, while 10% were in the Northeast, 14% in the Midwest, and 21% in the West. All right, now that we've taken a look at different communities and different risk factors for HIV, let's talk about prevention and treatment. Despite dramatic medical advances in HIV prevention and treatment, HIV remains a serious problem in the US. So again, we still have around 30 to 35,000 new infections each year, which are preventable. To protect ourselves, we need to honestly assess our risks and act to avoid acquiring HIV. And fortunately, there are a lot of choices more than ever to protect yourself. Some of those are things like reducing the number of sex partners and using condoms consistently if you choose those routes. I think a more effective and empowering approach potentially to reducing your risk for HIV is starting pre-exposure prophylaxis, or PrEP. So PrEP is a medication shown to be safe and highly effective in blocking HIV. It can be used by anyone who would like to lower their chances of getting infected. The drug is not just available to gay men or transgender people, it's for anyone who thinks they would benefit from PrEP, and if so, you should talk to your provider about it. If used correctly and consistently, PrEP reduces the risk of getting HIV from sex by more than 90%. And this sort of varies a little bit depending on risk factors, but it's somewhere, if you use it correctly and consistently, in the upper 90%. So it's very effective. And now there are many types of PrEP that can fit in with people's lives, including daily oral medications, every 2 month injections, and as of 2025, there's even a PrEP injection that you only have to get every 6 months. Another option for emergency situations is post-exposure prophylaxis, or PEP. So this is the use of HIV medications after being potentially exposed, such as after a sexual assault or other unanticipated situations. Again, this should only be used sort of in an emergency way. And finally, as I mentioned before, treatment as prevention, or U equals U, is when people who have HIV are correctly taking their medications and they are undetectable and they cannot pass HIV through sex. An important part of staying healthy is knowing your HIV status, and that, of course, means testing for HIV. The CDC recommends that everyone between the ages of 13 and 64 get tested for HIV at least once in their lifetime. This is because in the US, 1 in 7 people who have HIV actually don't know it. And again, that's the group where they don't know their HIV status, and so they're more likely to pass HIV to sexual partners. People at higher risk should get tested more often, such as yearly. Deciding when to get tested depends on when you may have been exposed and which test is used. Specifically, when someone is exposed to HIV, the immune system usually takes 3 to 8 weeks to produce antibodies. However, tests differ in how soon that they're able to detect antibodies. So the window period is a time period between infection but prior to a positive result, usually on an antibody test. In cases where the exposure was recent, a different test may be ordered that is more sensitive. So there are a number of different kinds of tests for HIV. A nucleic acid test, or NAT, looks for the virus in the blood and can detect HIV sooner than other tests. An antigen antibody screening test for both HIV antigens and antibodies, while an antibody test screens only for HIV antibodies. There are two home-based rapid tests that you can use that are approved by the FDA. One is the OraQuick rapid test, and you can get results at home in 20 minutes. And a recently FDA-approved home-based test is the Insti HIV self-test, where you can get results in as little as 60 seconds. In any case, if someone has a positive or indeterminate result on a rapid test, a follow-up diagnostic test is needed to confirm it. So if you test positive, your sexual and drug-using partners may also be infected, and of course, they should be tested as well. Most people living with HIV who do not get treatment eventually will develop AIDS. So the standard of care right now is to test, and if that person has HIV, then to begin treatment right away. That's called a test and treat strategy. Treatment for HIV is called antiretroviral therapy, or ART, which is in general is a combination of drugs that can be taken orally, or now there is an HIV treatment that is an injection. The goal of ART is to suppress the virus enough so that it does not severely affect the immune system. A benchmark to what is considered virally suppressed is to have less than 200 copies of HIV per milliliter of blood. Even more impressive is that ART slows the progression of the virus by reducing viral load in the blood and body fluids to levels that cannot be detected by current tests. Now, current viral load tests can measure up to 20 particles of HIV per milliliter of blood. So that means if someone is undetectable, they have less than that in their system. People with HIV are living longer, healthier lives today thanks to new and effective treatments. And ART prevents the sexual transmission of HIV to sex partners when taken correctly. So there are huge benefits to starting ART right away. For people with HIV, it is important to find a physician who has experience working with HIV and who is sensitive to the issues confronted by patients living with HIV. In addition, people with HIV may have a number of other mental and physical health needs, as well as assistance with things like housing, employment, and addressing substance use. So, for a lot of well-resourced HIV clinics, what we call sort of wraparound services, uh, they include those. And this is not only sort of physicians to treat HIV, but also includes people like social workers, substance use treatment specialists, and other services within the clinic. Now, another part of the chapter that I just want to mention that feels a bit outdated is the advice that sexual partners who both have HIV should use a condom because of the concern that one partner might pass a different strain of HIV to the other partner. So, this was a concern probably 10 to 15 years ago among researchers, but it really hasn't proved to be a significant problem clinically. I think most physicians and also most prevention experts at this point would say that it's fine for people who are exclusive and are both living with HIV to have sex that doesn't necessarily include a condom. I think a more realistic reason to use a condom between people who both have HIV is to avoid other sexually transmitted infections like syphilis. Now, in any case, living with HIV is a very different experience than it was even 10 years ago, and certainly a completely different experience than it was in the 1980s and 1990s. With proper treatment and care, people with HIV can lead long, fulfilling lives. And that is the end of this presentation.